Well, hello and good afternoon, everyone. Welcome to Roswell Park's webinar for first responders. I'm Rebecca Vogt. I'm the Media Relations Specialist here at Roswell Park Comprehensive Cancer Center in Buffalo, New York. I want to say thank you to those who are tuning back in and a heartfelt welcome to all of you who are watching for the very first time. We see all of you day in and day out, your selfless dedication toward putting the safety of your community first. But now it's time to focus on you and your health. And today we are going skin deep. As with each of these webinars, we do hope that we can provide support and education to keep all of you healthy. Two wonderful individuals joining us on the call from Roswell Park today. I am joined by Dr. George Parag and Dr. Michael Bax. They both co-chair the Department of Dermatology here at Roswell. And of course, a very big welcome back to Mike Valenti, who serves as president of the Firefighters Cancer Foundation of New York, and for the last 16 years has been an active member of the Syracuse Fire Department. Dr. Parag and Bax, tell us a little bit about yourself and your work. And Dr. Parag, we will start with you.
I'm George Parag. I'm a medical dermatologist here at Roswell Park, and our goal here at Roswell Park in the medical dermatology area is really to diagnose skin cancer as early as possible and also to prevent skin cancer from coming up by treating precursor lesions and by eliminating early changes in the skin. That's also my research focus and my clinical focus, and we're essentially here sort of as a service to the community to try to eliminate sort of the burden that skin cancer poses on our community in Buffalo.
Thank you so much. Dr. Bax?
I'm Michael Bax. I'm a dermatologist here at Roswell also. I'm also a Mohs surgeon, so specifically treating certain types of skin cancer with a procedure called Mohs surgery. So after a patient's already diagnosed with skin cancer, they'll come to me or my colleague, Dr. Brady, and they'll have a procedure called Mohs surgery done to treat these forms of skin cancer that are diagnosed by people in the community, as well as our dermatology clinic here at Roswell.
Excellent. Thank you both for that introduction. Our goal here at Roswell Park is to create comprehensive programs for screening and treatment of our local and state first responders. Our dermatology department has taken a very special interest here locally in Buffalo to provide comprehensive skin screenings for first responders in our community. And we're going to cover why this is an important topic for you and how you can stay on top of your skin health. We, of course, are going to leave time open for questions, a little question and answer session following the presentation. And you always have the option where we have a couple of pre-submitted questions, but you can also drop down to the chat down below, submit what you like, make sure it's to all presenters. We're going to be monitoring the chat, and again, try to get to as many as time allows. And we'll also always toss it over to Mike for any sort of regional or state updates before we end our time here today. And of course, submit as many questions as you would like to. And again, we'll try to get to as many as we can. Dr. Parag and Dr. Bax, I will turn the mic over to you and step aside, and I know you guys have a great presentation. One of you guys can start.
I'm going to start. I'm just unmuting everything, and I'm sharing my presentation also.
Perfect.
So hopefully everyone can see the presentation, and we'll see how I'm advancing it. So we prepare to talk about skin and skin cancer mainly. In order to try to advance it. So in order to talk about skin cancer first, we wanted to talk about skin in general. Later on, I'll talk about melanoma and what we need to bear in mind to be able to recognize melanoma early. After that, Dr. Bax will talk about non-melanoma skin cancers, the most common human cancers, and then he'll also talk about skin cancer prevention. The skin is our largest organ. It is the most visible of all our organs. It is constantly exposed to outside environmental factors, from chemical agents, irritants and allergens, to physical agents, to mechanical trauma and biological agents. I'm sure that many of you can relate to this. The most important function of the skin is to protect our body from all these external stimuli, to provide mechanical protection, to regulate the body's temperature, to provide sun protection, to provide a barrier against microorganisms. But it also has some metabolic functions. It is capable of generating vitamin D. It also detects sensory stimuli. It has an excretory function. And obviously it also has an aesthetic and psychological role. But don't forget that the most important function of the skin is that really it is the first line of defense against everything that is capable of hitting our body. In order to sort of fulfill this function, the skin is an intricate organ made up of 3 distinct layers. The sort of lowermost layer is the subcutaneous layer, which is sort of the padding underneath the rest of the skin. It's mainly composed of adipose sites, so fat cells. Overlying this, there's a dermal layer, which is really important because it provides much of the elasticity of the skin. And it also supports the overlying layer, the epidermis, which is really that first line of defense that we'll talk more about. The epidermis, in order to be able to sort of become this defensive force, needs to have an intricate balance between renewal and sort of shedding. And that's mainly reliant on keratinocytes or squamous cells. But it also has an important function in protecting us from sun exposure, and this function is mostly reliant on melanocytes. It also has, or pigment cells. It also has other cells that are capable of sort of fulfilling some of its functions, but those I'm not going to talk about today. The squamous cells or keratinocytes are very important because they are the ones that actually will mature and differentiate into a shield all over our body, which is called the stratum corneum, which is composed of both a chemical protective interface made up of lipids and also mechanical protective interface made up of protein, sort of the dead scaffolds of the former keratinocytes. Whereas melanocytes are important because they reside at the bottom of the epidermis, but they produce pigment for all the cells, all the keratinocytes in the epidermis, and also themselves to protect the cells from UV light, from sort of sunburn, and also other detrimental effects of sun exposure. First, we'll focus on sort of what happens if these melanocytes go away and if melanoma arises. Melanoma is probably one of the best known skin cancers to all of you, and it's mostly due to the fact that it has had a staggering increase in incidence. We'll review some of the numbers on melanoma. We'll talk about also its origin, although I alluded to it already. We'll then talk about melanoma subtypes to better understand what melanoma looks like. And then we'll talk about some things that you need to also understand to be and know about to be able to differentiate problem spots on your skin from benign lesions. And later on, we'll discuss sort of what morphology to be most worried about and what to focus on. And then at the end of the whole presentation, actually, Dr. Bax will talk about a tiny bit about how we actually diagnose skin cancer. As I mentioned, melanoma unfortunately has shown an exceptional rise in incidence. This is the major cancer that has shown the highest increase in incidence in the past decades. Currently, the lifetime risk of melanoma stands at around 2.3%. So approximately 1 in 43 people will be diagnosed with this disease throughout their life. The problem also with melanoma is that it doesn't only affect older individuals, it actually affects a disproportionate number of younger individuals. The median age of diagnosis is 53 years, and it is actually the most common cancer of women aged 25 to 29, which obviously creates also a lot of problems. The number of people living with history of melanoma is well above 1 million in the United States. And this is all not counting in situ disease, so the form of melanoma that has not yet sort of gained the ability to spread to other parts of the body. All the numbers are really only for invasive melanoma. The big problem with melanoma is that you don't need large burden of disease to cause major problems and to potentially spread. Sometimes melanomas that are no greater than a grain of rice can potentially spread to other areas of the body and cause metastatic disease. Luckily, however, by early diagnosis, we are able to catch many of these melanomas before they have that ability, and therefore the 5-year mortality of melanoma, if invasive melanoma overall, is luckily only at 8.2%. But still, that's a very high number of people that we lose because of this devastating disease. What determines survival? It's important to know that multiple factors determine it, including patient characteristics, tumor characteristics, and obviously also available treatment options. What's really most important to recognize is that early melanoma diagnosis is key. If it's diagnosed extremely early, this is a very treatable disease, whereas if it's diagnosed late in life, even with the modern techniques, unfortunately, we can't save everyone. To go back to where melanoma comes from and to better understand sort of what melanoma looks like, again, we need to understand that melanoma is a cancer of pigment cells, melanocytes. These are the same cells that are responsible for the color of our skin, and these are the very same cells that are responsible for tanning when we go out into the sun and when we get sun damage to our skin. However, when these cells get damaged, sometimes they can show local proliferations and local growths, and you can have uncontrolled growth of clumps of these cells forming these tumors. And obviously, as these are pigment cells, many of these lesions will have pigment in them, but not all of them, as I'll show you in a short time on a couple of the clinical images. In order to also better understand melanoma, we also need to realize that melanoma is a class of diseases in reality. The most frequent melanoma subtype is superficial spreading melanoma, but I'll also talk about other subtypes to better understand what you need to look for, because unfortunately some of these other subtypes, because they are less well known, are actually a lot more devastating because they are recognized later. Superficial spreading melanoma, as I mentioned, is the most frequently seen subtype of melanoma. It usually presents between the age of 30 and 50, but it can also happen and present earlier or later in life. It can come and rise de novo, so can come in a perfectly normal looking skin area as a new melanoma, or it can also occasionally arise in a pre-existing mole. Most commonly, it will actually come in what we call intermittent sun-exposed areas of the skin. So areas of the skin that are not constantly exposed to the sun, but which get occasionally a lot of sunlight and therefore burn occasionally. It is known to be associated with the number of early life sunburns. And Dr. Bax will talk more about that. Luckily, this is a melanoma subtype that usually goes through a relatively long initial phase and also a relatively long radial growth phase, where it will be spreading superficially on the surface of the skin before it learns to sort of grow deeper. And this is important because once it learns to grow deeper, it becomes a potentially more devastating disease during the radial phase. That's when the tumor may become bumpier. Often in these superficial spreading melanomas, what you will see is you will see an asymmetric sort of macular papule or patch, depending on the size and sort of other features. You will see border regularity. You'll see multiple different colors in the lesions, and you'll also see larger diameters. And if you're a good observer of your skin, you will also notice that you have change and evolution of these areas, as opposed to other benign lesions on your skin. We'll talk more about that later. Nodular melanoma is the second most common subtype. It presents more sort of later in life, usually in the 6th decade of life or after. It really skips the radial growth phase. It essentially presents with a rapid growth towards the depth of the skin, and that's what causes the problem. Because it grows deep, it very early on can potentially metastasize and cause devastating disease. It frequently presents in highly sun-exposed areas, as opposed to the superficial spreading melanoma, very frequently on the head and neck areas, but also can present on the trunk, especially sort of shoulder and other areas where you have more sun exposure. It shows a prominent male predominance, and usually it will present later, then it's thicker, and therefore it will have poorer prognosis. These are some clinical images. Often in these nodular melanomas, you'll see a lump on the skin. Frequently, it will have a bluish black or sometimes tan pink hue. Don't always think that it will be a large mass on the skin. Sometimes it can be a relatively smaller black, annoying, slowly growing spot, for example, on the nose, like in that image in the middle of the screen. And occasionally it can actually resemble some of the atypical nevi that we'll briefly talk about, and may not have very overt features that allow you to diagnose them from yards away. And it may require really close clinical or maybe even sort of magnified imaging in order for us to recognize them. And sometimes, unfortunately, the pigmentation will not be as striking as you'd anticipate from a pigment cell lesion. Occasionally, it will be bluish in color. Occasionally, it will mostly be pink, and there's only going to be barely any sort of tannish discoloration. And then sometimes there's going to be no discoloration at all. It will be just a pink, small bump on the skin. Next, the melanoma subtype that I wanted to talk about is acral lentiginous melanoma. And this is one that's often forgotten. everyone remembers that melanoma is related to sun exposure, which it is in most cases. But in this particular subtype of melanoma, it's actually thought to be related mostly to trauma and other factors, potentially also obviously genetic predisposition. This is luckily a not very common melanoma, but it unfortunately disproportionately affects darker skin types. And it can be a devastating disease because as people often don't think of their feet, of their hands as potential sites for melanoma, they may brush off a pigmented lesion or a discoloration in the nail unit as just, oh, something that I bumped, and therefore it may actually get diagnosed later in life. These are clinical images of acrolentigenous melanoma. This is obviously a nail unit affected by it. And this is the sole of a gentleman affected by acrolentigenous melanoma, where you will see this characteristic sort of ill-defined discoloration of a larger area. Obviously, these are not the times when we want to catch them. We want to catch them a lot earlier when they are much smaller. Last but not least, let's talk about lentigo maligno melanoma. This is a subtype that is a bit easier to catch because often it will present in highly sun-exposed areas of the skin, which are also more visible for other people. It usually will go through an extremely long radial growth phase, during which for 5 to 20 years it will grow slowly, allowing us time to catch it before it goes into the deep growth phase when it could create more trouble. This is responsible for approximately 4 to 15% of melanomas, and it mostly affects the nose and the cheek. And because of the slower growth and because it's caught often earlier, oftentimes this is better behaved. But because of the location, it's obviously still a great concern, and it still is something that we want to diagnose as early as possible because it often affects cosmetically very sensitive areas, and therefore you want to do surgery or treatment on these in an early phase where any surgery is as little disfiguring as possible. These are some of the clinical images. As I mentioned multiple times before, early diagnosis is key for all melanoma subtypes. And you know, you may say that that's easy. I mean, everyone will recognize a sort of a bump or an ill-shaped blotch on their skin, but we should not forget that all those photoshopped or sort of manipulated images on social media are kind of fake. And usually the human skin looks more like this rather than what you see here. So usually the human skin is covered by benign skin lesions, and we need to be able to differentiate these benign skin lesions from problem lesions in order to appropriately diagnose them early. And this is why sort of there are guidelines for people to use to know what to look for. Obviously, all of the spots that you see up here are benign lesions. The problem also is that even melanocytes can have growths on our skin that may sometimes resemble some early melanomas, which are completely benign. These melanocytic growths include congenital nevi that will have been present from the beginning of, I'm really sorry, from the beginning of life, and again may share some features of melanomas, but usually there's going to be a history of lack of change. So again, evolution, think of that. I discussed that that's an important factor in problem lesions. These lesions will show stability, even if they have multiple colors in them, or they have slightly unusual borders or slightly unusual bumpiness within. There can also be acquired nevi, which usually will be nice and symmetric. They can sometimes be discolored and pigmented. Occasionally they can be pink or perfectly skin colored, but usually again, these will be fairly stable, or the growth that you'll see in them will be sort of parallel in multiple similar lesions. Sometimes obviously we'll see more concerning lesions. Some of them may even be very hard for us under magnified images to fully differentiate from problem spots. We can also occasionally diagnose what we call atypical nevi. These are also considered benign entities, but they have some characteristic, not just clinical, but also histological features, where we see that the melanocytes have kind of gone down on the path of turning bad, but luckily they stopped and they never completed sort of finishing that path. One question that we often get asked is sort of, where do melanomas come from? So I wanted to kind of preempt that question by telling you that most of the melanomas actually come from perfect normal looking skin, de novos, about 60%. But it is important to know that yes, moles can also turn bad. And this is why looking at your moles and making sure that you understand if they are changing is so important. A small subset of melanomas actually can form from previously completely benign moles. It's about 20% of melanomas, and a small subset can also come from atypical nevi. But overwhelmingly, benign moles and atypical nevi are not expected to turn into anything concerning. They are expected to actually stay what they are, and it's only really a small subset that will turn into problem spots. I mentioned that I wanted to go through all these so you understand more about melanomas, but I also wanted to give you some cues as to how to diagnose them easier. I didn't want to confuse you. I wanted to kind of show you the full spectrum, but this is, I think, what will kind of help you simmer down what to remember. What you really want to remember is to carefully continue to examine your skin. Make sure that you recognize lesions that have a lot of asymmetry, border regularity, color, variation, variability, that have a larger diameter. The cutoff is 6 millimeters, so roughly the size of the eraser on the end of the pencil, and to recognize lesions that are changing on your skin as opposed to all the other spots that seem to be completely stable. One other thing that can help you is what we call the ugly duckling sign, which I usually add to the end of the ABCDE as an F, funny or funky. Anything that really stands out of the crowd can potentially be of concern. This is a cartoon that I love because it really very well depicts that. So what you really need to look for is something that looks completely different than other spots, because that's sometimes what helps us. Because sometimes people will have multiple benign moles, but they may recognize that they have something that looks, although not in line with any of those features very obviously, but something that looks very different, and that may help us catch the melanomas earlier. And with that, I'm going to turn over the mic to Dr. Bax to talk about non-melanoma skin cancer. Let me stop sharing here.
Thanks, Dr. Pratt. I'm going to queue up my slides, and then we should be good to go. All right. Does it look correct in terms of the presentation mode? Great. So we're going to talk about the other major category of skin cancer, the non-melanoma skin cancer. George did a great job. Dr. Pratt did a great job covering that part. This part actually covers the most common cancer that's diagnosed in humans, and it doesn't even make the charts. When you look at charts of most common cancers in men and women, when we look at skin cancer on those charts, melanoma is the skin cancer that gets all of the attention. There's boatloads of other types of skin cancer, and they're not included on this chart because the reason being, if they were, they would outnumber the rest by so much that there would really be no comparison. So if you look at this, just gives you an idea of how common non-melanoma skin cancer is relative to other types of cancer. Fortunately, these types of cancer, when caught early, and the majority of them are very treatable, and the majority of them are curable. So that's the great news. But they are extremely common and something that deserves a lot of attention. The two most common non-melanoma skin cancers, and what we'll spend the most time covering today, are specifically two types of cancer, one being squamous cell carcinoma, the other basal cell carcinoma. These are the main components of non-melanoma skin cancers. We'll start with squamous cell carcinoma. This is very common in sun-exposed areas, and the incidence is around 400,000 to around 1 million new cases that are diagnosed annually in this country. When caught early, they're very treatable and completely curable, but more aggressive squamous cells can behave more aggressively. And what I mean by that is potential to spread to other parts of the body. The main key throughout this whole talk is early detection and early treatment. But squamous cell carcinoma can metastasize. It's thought that the 5-year rate of metastasis is somewhere between 3 and 5%. And after adequate treatment, there is even a small chance of recurrence, meaning that the spot grows back after it's treated. And that is somewhere around 8%. We know that in addition to spots growing back at the site of treatment, they can also, people are more commonly develop new lesions elsewhere. So just because you've had one lesion biopsied, adequately treated, there's both a risk of that spot growing back in the location of the treatment, as well as a risk of new lesions popping up elsewhere that are completely unrelated to that initial lesion. Different factors about that squamous cell skin cancer influence the likelihood of those lesions growing back or potentially spreading. So the size of the lesion, we know that anything greater than about 2 centimeters in size has a higher rate of recurrence as well as metastasis to other parts of the body. higher risk locations, so certain locations on the body, specifically the lip, the ear, another one being the scalp. We know that larger squamous cells in those areas can behave more aggressively. We also know that squamous cells that occur on chronically damaged skin or injured skin or a burn scar, for example, those specific types of squamous cell carcinomas can behave more aggressively, as well as ones that have certain histologic features. What I mean by that is when the pathologist looks at it under the microscope, they look at those individual cells and they look at the features of those cells and whether or not they involve nerves. And if they do, that is a risk factor that means that that squamous cell may behave more aggressively. There's also certain patient factors that can influence the behavior patterns of squamous cell carcinomas, specifically the patient's immune status. So people who are immunosuppressed from other types of cancer, lymphoma, leukemia, patients who have had a transplant of an organ or a bone marrow transplant, their immune system doesn't work as well. And as a result, squamous cells are not only more likely to occur, but more likely to behave more aggressively. There's a lot of different variants of squamous cell carcinoma. I'll go through a few of those, Carotoacanthoma being one, very superficial squamous cell, something called squamous cell carcinoma in situ, and then there's invasive squamous cell carcinoma of the skin. Carotoacanthoma is a specific type of squamous cell carcinoma of the skin that can grow very rapidly, often stabilizes in growth. And there's also a small subset of these that can actually resolve and go away completely on their own without any treatment. They look classically, they look just like a well-differentiated squamous cell carcinoma, and they're even sometimes very hard to distinguish by the pathologists what is truly a squamous cell carcinoma versus this entity called a Carotoacanthoma. They're usually a single lesion, and by nature, a true Carotoacanthoma should behave in a very favorable pattern. But the inability to distinguish it from a well-differentiated squamous cell carcinoma is what can be difficult, and oftentimes they're treated as a true squamous cell carcinoma. This is an example of what you see here on the skin. It's almost a volcano-like appearance. They can occur very rapidly. They can be very painful. They often have a crust or a crater in the center of just has dead keratin or skin in the center of it. And this is a pretty classic example of that. Here are a few more. And as you can see, they can start fairly small, but can grow to be very large and can be quite destructive on the skin. The next type of squamous cell carcinoma is something called squamous cell carcinoma in situ. Another name for this is something called Bowen's disease. It often occurs later in life on chronically sun-damaged skin. So you can think about essentially sun-exposed areas, those being the face, the head and neck areas, the backs of the hands, places that have just had long-term chronic sun exposure, whether it be from work-related activity or recreational activity. It's very common in those areas. They can occur de novo, meaning on their own, or they can occur from pre-existing precancerous lesions, something called actinic keratoses, which are very common and one caught early can be treated and prevented from turning into squamous cell carcinoma. They can sometimes look like another type of rash on the skin, something like psoriasis or eczema, but usually we tell our patients that if you have a patch of eczema and you're treating it as eczema and it doesn't go away, that's the sign that that lesion should be biopsied because it could potentially be an early skin cancer. Here's some examples of it here. You would think that normally if you saw this, you'd say, oh, I'm gonna put some cortisone on it, put some cream on it, and hopefully it should heal up pretty quickly, but these will not. They may get a little less red occasionally, but they'll grow back. And they won't go away. And when that happens, it could be a sign that this is an early skin cancer and you should see a dermatologist and have a biopsy of this lesion. When that skin cancer has a chance to go into the second layer of skin, by definition, it's something called an invasive squamous cell carcinoma. Why that's important is because these types of skin cancers can have a tendency to behave a little bit more aggressively and should be treated more aggressively as a result of that. So superficial squamous cell skin cancers, when caught early and confined to the very top layer of skin, are more amenable to superficial treatments like freezing, some topical therapies that you can apply to the skin, superficial scraping procedures. But invasive squamous cell carcinomas most often are treated surgically. And they also occur in a similar fashion, a little bit later in life on chronically sun-damaged areas, in areas that just had repeated sun exposure over the years, head and neck, again, back of the hands. And they can look similar to other types of skin cancer, but they can also resemble a warty type of growth on the skin. That's most often the classic appearance of the squamous cell. They can also be painful. Occasionally they can bleed. Those are common complaints with squamous cell carcinoma. Here's some examples here in different areas. And I mentioned some of those higher risk areas like the ear, the lip, and these are a few examples of what it may look like on the skin. Some other areas here, Dr. Pra mentioned how melanoma can also occur around the nails. Squamous cell is one other skin cancer that commonly does affect the nail. We actually see it quite a bit where someone thinks that they have a fungus of the nail or a warty type of growth around the nail. But that also could represent a squamous cell carcinoma, should have a low threshold for having a biopsy of that lesion. Here's another squamous cell cancer that has what we will call a cutaneous horn on it. So that rough, very firm, dead skin scales that kind of pile up on the surface. That's often a sign of an underlying squamous cell skin cancer. Shifting gears a little bit to the most common cancer that's diagnosed in humans, something called basal cell carcinoma. There are millions diagnosed every year in the US, a little more common in men than women by about 2 to 1. And the risk factors for this, we talked about squamous cell skin cancer where it's chronic, everyday UV sun exposure. Basal cell, we seem to think may be more involved to intermittent, intense sun exposure. So not so much that everyday person who's working outside and not wearing their sunscreen, but someone who just has a history of having 2 or 3 really bad burns throughout their life, and they can recall those instances very quickly. And when they had that one bad blistering burn while at the beach, or a couple of those throughout their life, those are the people who put themselves at increased risk for this type of skin cancer. Again, they do often occur on the head and neck and the sun exposed areas, but they can occur anywhere. And that goes with squamous cell as well, not only on the sun exposed areas, but also other parts of the body that don't often see the sun. So even though if you have a lesion in those areas that you don't think it can be skin cancer because it's not sun related, it's certainly still something that you should have checked out. There are several different varieties of basal cell, and it gets into more or less what we see under the microscope when we look at these, what these cells look like when we look at them under the microscope, and that puts them into a certain category. But the good news and the bottom line is basal cell skin cancer, when caught early and treated appropriately, almost never metastasizes. We never say never in medicine, but this is about as close as we get when it comes to catching basal cell and preventing it from spreading. Has a very low risk of doing that. Sorry about that. So when you look at them under the microscope, this is what you'll see. Apologize, someone's persistent. When you look at them, you'll see these cells underneath the microscope, and they come from the specific area at the basal layer of the skin when you look at the epidermis. And that basal layer are the cells that when they have enough damage over the years, can mutate and turn into a cancer. So that's why it's called basal cell carcinoma. Nodular basal cell carcinoma is the most common subtype. It's about 60% of all basal cell skin cancers. They occur most commonly on the face, and they have this very classic pearly appearance with some broken blood vessels at the top of them. And they can grow large, they can extend deeply, and they can outgrow their blood supply. And then when that happens, it creates a sore on the surface or an ulceration. They can also be pigmented. So here's some examples of several nodular basal cells, and these are pretty classic appearances. When patients come in and they've been diagnosed with the basal cell, I always ask what it looked like, how did it start? And the most common complaint is that it starts as a pimple. So it's this pimple that just never healed. And usually I tell people that a pimple should go away within 1 or 2 weeks. Basal cells will not go away within 1 or 2 weeks. If you have a pimple and it hasn't gone away after a couple of weeks, it's a sign that this could be a very early superficial skin cancer and it should be checked out. So usually after a couple of weeks, if it hasn't gone away, I usually tell people get in to see somebody and have it sampled, because that is a classic explanation of how these start. Some more examples here of basal cells occurring on the nose. Again, a very classic appearance and a very common location for this type of cancer. They can occur anywhere. Here on the lower eyelid, we see these very commonly. In a sore here on the inner canthus there near the eyelid. So if you go back, this more commonly people would say, oh, I thought it was just a sty or something near my eye that just never went away. And oftentimes they kind of progress and not always get to this point until they're detected, but this is kind of how they can advance and progress if not treated. Some more examples here, very common appearances, classic for basal cell skin cancer. You can see the pigmented variety in these examples on the nose, as well as some superficial specks of pigment throughout the other lesions as well. Another type of basal cell skin cancer is a superficial type, and that really just explains the location on the skin surface that they are. So these are confined to the very top layer of the skin. They're the second most common variety of basal cell and occur in about 15% of cases. These, on the other hand, other than off the face, they occur on the trunk and the extremities, and oftentimes similar to certain types of squamous cell, can have changes that look like eczema or psoriasis or other types of rashes that people don't often affiliate with skin cancer. Here's some examples here again that could look like any other rash: dry skin, it's the winter months and you're not moisturizing and you have this patch on your skin and it just doesn't go away. And oftentimes that's the story when people come in with superficial basal cell skin cancer. Another example of that here. And some more of the same. So another type of basal cell skin cancer is called morpheiform, and all this essentially means is the description of that name. Morpheiform is scar-like, and these can be more subtle on the surface of the skin, and they can also be more deeply penetrating and very locally aggressive. They're flat. Sometimes they have a depressed scar or an ill-defined plaque, and what you see on the surface often is just what I tell patients can be the tip of the iceberg. So what looks like a very small area on the surface of the skin, looks like a small scar, often can have a much larger lesion underneath the surface of the skin that we don't see until we look at the edges under the microscope and see that these actually extend well beyond what you see on the surface. Here's some examples of it here, some scar-like growths on the forehead or the cheek or on the lip in these individuals. And another one here on the nose. So again, the take-home point here is they extremely rarely metastasize. They grow very slowly over months to years, but these are truly still a malignancy. And people often ask, well, if they grow so slowly and it's not going to kill me, why do I have to treat it? And the reason being is that they will continue to grow and they essentially will destroy anything in its path if not treated. And you could see some examples of these here, some more advanced basal cell skin cancers on the temple, on the lip, and on the nose. And they can really be quite destructive. And at this point, they're often much more difficult to treat. And if they are treated, they often can result in scars that are very deforming. So that's why we counsel our patients on the risks of not treating them and the risks of identifying them early and getting them treated. So I talked about the main risks involved with basal cell and squamous cell skin cancer, and it really comes down to sun exposure and preventing yourself from burning. And there's a lot of other factors that go into developing skin cancer, and relevant to this talk with first responders, I know there's been a lot of research specifically on first responders and firefighters that have increased rates of cancer overall, but there's also been some research specifically looking at skin cancer in first responders and firefighters. And the little data that is out there, unfortunately, it's getting more attention, so I think we'll see some more research on this soon and some more data coming down the line. But they are showing, the early reports are showing that firefighters are actually at increased risk of skin cancer overall, but also developing earlier than the general population. So for example, if the average person develops their first skin cancer at age 50 or 60 or 70, the firefighter probably develops it maybe at age 40, for example. So that's why it's important to get things checked early and often, and if you have any suspicious lesions, to have them evaluated. The reports that I've read haven't really gave specific reasons as to why maybe firefighters could be at increased risk. It could be a combination of exposure to chemicals or things that they're exposed to while performing their duties. And that combined with UV radiation from the sun, whether it be work-related exposure to the sun or recreational-related exposure to the sun, kind of potentiates that risk and puts them at increased risk of developing these earlier. Genetics can also play a role. So people often with a strong family history of skin cancers are at higher risk of getting more. There are some rare genetic conditions that can predispose you to skin cancer. And then once you have one, I usually tell people your rate of getting a second is somewhere around 50%. So it's not that individual skin cancer that we're treating today that can grow back. The risk of that is actually very low. But the risk of you getting another lesion in a completely different location is actually probably somewhere around 50%, which is why once you've had one, you usually bought yourself a skin check at least once or twice a year for life. Some different things to look at will put you at increased risk of basal cell cancer and squamous cell skin cancer. Anybody with fair skin, anybody who easily burns and has a very difficult time tanning, anyone who has freckling on the skin, and we know that people with red hair lack the pigment to protect them from developing these skin cancers. Skin cancer can develop in darker skin types, so definitely not something that you want to ignore. All different types of skin cancers can. Melanoma, which we know melanoma can behave more aggressively in darker skin types because it's diagnosed later, and people don't often think of skin cancer in people with darker skin types. So usually by the time you catch the melanoma, it's actually more advanced disease. So as a result, people will have a poor prognosis. But the more common type of skin cancer overall and specifically in darker skin types is basal and squamous cell carcinoma. And again, like any other basal or squamous cell skin cancer, early diagnosis makes treatment easier, and even easier is to prevent it in the first place, and that's the key. So how do we prevent it? Well, first and foremost, primary prevention by preventing the sun damage in the first place. And this starts in childhood. And now that we know more about skin cancer and risks in general, we counsel our patients, if you have kids, start protecting them now, because a lot of the damage is done throughout childhood, young adulthood. And by the time you're getting your first or your second skin cancer, unfortunately, a lot of the damage has already been done. But it is still important. Every little bit you can do to protect yourself from the sun now going forward is going to help. Secondary prevention, diagnosing these early. So not waiting when you find a new spot that's not gone away in a week or two, having it evaluated by a medical professional and having it biopsied to rule out an early skin cancer, and to treat any existing precancerous lesions is very important. And then tertiary prevention, treating the cancer when detected to reduce the long-term complications. We know UV light does damage to the DNA of our skin cells, and that's really the main crux behind how these cancers develop. When you get a tan, everybody wants their healthy tan throughout the summer. That tan is actually your body's defense mechanism. The melanin, or that pigment that's produced by your skin cells to give you that glow or that tan, is actually your body's way of spreading that melanin to a different layer in the cell to protect the nucleus, or where that DNA is housed in that cell, from the damage. It actually, that melanin is designed to shield the DNA from the damage. So that healthy glow is actually your body's cry for help. And that's how the tan starts, which I just reviewed. So again, don't burn. That's the most important thing. Avoid tanning. There's no such thing as a healthy tan. Seek the shade when you're outdoors. Avoid the peak hours between 10 and 4. I tell people you don't have to be scared of the sun. You just have to be smart about it. You can go outside and do the things you want to do, but cover up, wear a hat, wear sunglasses, sunscreen, sun protective clothing if you can. And people always ask, what's the best sunscreen? And I'm not very brand loyal or partial to any one specific sunscreen or another, but at least if you're using an SPF of 30, you'll get the majority of the coverage that you need. And then that you're putting enough on and reapplying it when you are outside for more than a couple of hours, or even more frequently if you're sweating or getting it wet. Because sun, in addition, if the skin cancer part of sun damage and all of this talk doesn't scare you, the vanity the vanity behind it all, and the cosmetic results from sun damage is always what will scare the rest of people. Because when you look at these pictures and you see the damage that the sun can do to the skin, non-cancer related, it really is kind of striking. And one of my favorite pictures is the one on my far right of this person who was a truck driver. So you notice the left side of their face is extremely wrinkled, and the right side is much more normal looking. And that's the result of the sun damage going right through the truck window throughout their career as a driver. And you could see how much of a difference the exposed side, how much different it looks from the non-exposed side. Self-skin checks are very important. And anyone who has any history of skin cancer, it's very easy to do at home. We usually tell people to do this once a month, every couple of months, between visits. And if you ever notice anything suspicious, that would be what you want to bring into our attention, and not to wait until your next scheduled appointment. Come in sooner. And it's very easy to do both by yourself, or if you have a friend or a family member at home that can help you with a mirror and a hand mirror, you can really look at your whole body. And I tell people, take pictures of lesions now, because when they come in and we'll point out things, it's very easy to take a picture of it and check it from month to month. If there's any changes, a skin biopsy is something that's very easy to do. And we have a very low threshold for doing one because there's very little risk involved, and it could mean the difference in saving a life. What you're looking for when you do these self-skin exams: growing lesions, sores that don't heal, things that bleed that shouldn't bleed, pimples that don't go away after a couple of weeks, or any new or changing scar. Is definitely something that you want to keep an eye on. So in general, skin cancers are extremely common, and the basis of this talk, the one take-home thing, is that prevention and early detection is key. And if anything else, protect yourself from the sun and check your skin at home. And if you have anything suspicious, get to your dermatologist and have it evaluated. Thank you for your time.
Fantastic. Excellent. Thank you for that. Thank you for that presentation. We do have a couple of questions that we want to get to. And actually, Mike himself, he will kick it off with his question. And he is saying, at what age should a person start seeing a dermatologist, and how routinely should they be going?
So I'll probably jump in and we'll try to answer that. So one of the things that is important to know is that it all depends. Because obviously, if someone has significant family history of skin cancer, the answer is going to be a lot more frequent visits than for someone who has absolutely no family history of skin cancer and no personal history of skin cancer. In general, the American Cancer Society recommends that one start seeing someone to do full body skin checks at the age of approximately 20, and until the age of 40, one should have approximately a skin check every 3 years. After 40, once a year is the recommendation. It's important to know that the data behind it is poor. It's more of an empirical recommendation. And again, if someone is diagnosed with skin cancer, and unfortunately, sometimes we diagnose people with skin cancer in their mid-20s, then the recommendation will be half-year follow-up for 2 years, and then after that, yearly follow-up if it's a non-melanoma skin cancer. If it is a melanoma, it may actually be every 3-month follow-up for 2 years, and then after every half a year until you're 5 years out, and after that once a year. So really it depends on a lot of factors and someone's family history.
Kind of speaking of those factors though, I mean, is there any recommendation that first responders do it, more frequently or even earlier? Because I mean, there's a lot of young men and women who are, joining up and doing this.
Absolutely. And the problem with that is that, there's clear data that first responders have a somewhat increased risk of skin cancer. The problem is that obviously the data is not sound enough to make sort of a fully data-driven recommendation. But what one could say based on that data that's out there, that probably what the general public does sort of a decade later should be done by first responders that decade earlier. So because of when they start developing skin cancer. And also don't forget that when it comes to skin checks, the other aspect of it is also going through appropriate photo protection and sort of coaching people through it so that they will be able to withstand the peer pressure on getting the healthy glow and the tan. And so overall, I'd say that probably first responders start having yearly skin checks at the age of 30, and really probably below 20, unless there's significant family history, there's no reason to do every 3-year skin checks, but from 20 to 30, every 3-year skin checks, that would be reasonable. But again, this is not data driven, and this is just something that I think makes sense based on everything that we see.
It does kind of lead me into the next question that we had pop up, which kind of draws into another question that I sort of had. So we have someone asking, can thermal burns from the job cause higher risk? And I know, Dr. Parra, you had mentioned that there is the one melanoma that can come from trauma. I mean, would that trauma include, say, suffering a burn or exposure at a fire?
You probably don't know enough when it comes to melanoma, but when it comes to squamous cell carcinoma, it is clearly known. So burn scars are notoriously and more likely to form squamous cell carcinomas, especially if it's in an area that also gets a lot of sun exposure. And also it depends on how fast the area heals. Very slow healing scars are always more likely to potentially result in squamous cell carcinoma formation. But yes, the answer is yes, and absolutely thermal injury and thermal scars are a problem. Even long-term thermal injury, so discoloration caused by long-term thermal injury can also be a slightly cause a slightly elevated risk of skin cancer.
So one thing that I have a question about is that, and I know both of you, you showed where, common places where both of these, all these types might be found, hands, face, trunk, that sort of thing. But some of these individuals who are tuning in, they're typically wearing turnout gear or some type of uniform. Is there anywhere on the body in particular that they should be concerned about, on their hands, on their face, or does the same sort of rules apply to them as the general public?
I think when it comes to on-the-job exposure, obviously the less amount of skin exposed, the better, I think, without a doubt. And I think the little data that is out there hypothesizes that it may be some factor of a work exposure combined with UV light exposure, whether it be also at work or if you're just out recreationally. So outside of work-related exposures, I would say the same rules apply when it comes to protecting your sun. Don't burn, put on sunscreen, wear protective clothing. All those same rules still apply.
Mike, I see that you're unmuted. Do you have a question?
I do. It's excuse the scruff. I was out getting some vitamin D in the river and came home to this. There's a lot of talk lately about the flame retardant material that is in our gear, in our uniforms that we wear, that it's cancer causing. Where do we draw the line of this, and what is actually causing the cancers from the flame retardant material we're wearing? Is there any?
So one of the things I would say about that is that obviously in a lot of aspects of sort of what you face, more data is needed. So I'm not sure that we have enough data to tell you sort of how it will increase skin cancer risk. But we do know that many chemical exposures actually can slightly alter how cells behave. And often that combined with other exposures like light exposure sort of cumulatively cause problems. So I would say that almost certainly more data will be needed to fully understand sort of how it may increase skin cancer risk and what skin cancers it may increase the risk of. But one of the things that you can always do, if you know that you're exposed to risks that are sort of at this point not fully understood, to reduce all other risks and therefore reduce the cumulative risk and overall decrease your risk of skin cancer.
One more thing I do want to mention and bring up. I know on one of the slides you had talked, there was the primary, secondary, tertiary, like sort of levels of screening. Is there any way whatsoever possible to sort of reverse skin damage, or like you said, once you get that first burn, that's already sort of causing that DNA damage?
This is a superb question. So this is actually sort of one of my research interests. And we do know that there are ways that we can sort of turn around skin damage and sun damage, because the damage actually accumulates in the skin in cell groups. And we have techniques to eliminate those and to prevent skin cancer potentially from forming. But this is actually sort of a new area of research. We've known about it for a long time, but we don't know enough about that really early phase of carcinogenesis in the skin to sort of know the total extent as to which we can sort of reverse what happened previously. One thing, however, that's important to realize, that probably even once we 20 years down the line will understand everything, we'll recognize that not all damage is fully reversible, because some of the damage will be sort of permanently present in groups of cells in the DNA. And even if it would be reversible, it would require extremely traumatic treatments in order to get rid of all those damaged cells. So really the first thing that people can do is to avoid the damage. If it happened, there are tools that we may be able to use to help them.
And just want to jump quickly previously back to Mike's question. And you talked about, you know, the data and the data not necessarily being there. I'm hearing that Roswell Park is becoming part of a national cohort study. Is that something that either of you could elaborate on?
Mike, do you want to?
We're starting a cancer screening program, which I could speak to specifically the dermatology component, in that any first responder, we're starting out small, building it up firehouse by firehouse, but we'll be offering skin cancer screenings to them, where they'll come in and if they wish, and they'll fill out a survey, which is part of the broader questionnaire for the research, and then they'll have their skin screening, which we're excited to be a part of. So we'll be rolling that out over the next little while.
That's excellent. Mike, I hear you got a couple of updates that you want to share, so I'll let you have the floor.
Well, we're just, you know, we're excited about the screenings that are going to be done. We know you're going to start in Buffalo and work with the Buffalo firefighters with this. And, excuse me, and we want to slowly be able to stretch this across the state so that firefighters all across the state can be tested by Roswell, and we can get our own study almost of firefighters in skin cancer across New York State. We know, you know, New York has a lot of different demographics that affect this, you know, and we want to be able to get a broad picture of what's going on. So we're very excited about this new screen that's going to come along.
Fantastic. Thank you, Mike, for that. Drs. Bax and Parag, do you have anything you want to say, any sort of takeaways as we wrap up this afternoon?
Just thank you all for your service. We do what we do because we're grateful to take care of you all. So we're looking forward to collaborating with you, and it should be fun.
Absolutely. And again, remember to know your skin. That's going to be very important in identifying any problem spots. And thank you again for your help in this, because obviously with you know, the firefighters sort of coming in and being part of this cohort, I do believe that we might be able to identify risk factors and sort of help other people prevent skin cancer better.
Thank you, everyone, so much. And also thank you to everyone who tuned in this afternoon. We appreciate it. Thank you, Dr. Bax and Dr. Parag, for this informative presentation. Now, of course, if any of you guys have any questions that, you know, once we end this, that you said, oh darn, I forgot, we do encourage you to tune into future webinars, and we're going to address, of course, even more topics and questions. Don't you worry about that. Our next chat is going to be scheduled for Thursday, October 20th. And if you'd like any additional information on screening, feel free to check out our First Responders resource page at roswellpark.org/first-responders. Now, the video from today is going to be available to view on demand on the aforementioned First Responders page, and a link is also going to be sent to your email. So stay tuned to roswellpark.org/first-responders webinar, and then, of course, your email to register for said upcoming webinars. To everyone out there, have a wonderful day, and thank you again for tuning in. Bye, everyone.